In the last part 2, we explored how widespread and clinically important inpatient hyperglycemia is and clarified the safe glucose ranges we should aim for. Now we move from recognizing the issue to actively managing it. In this part 3, our focus shifts to insulin strategies for non-critically ill hospitalized patients, ranging from basal bolus regimen to simplified approaches like basal plus and DPP-4 inhibitors combinations. We will examine the practical tools and supporting evidence that help us reach glycemic targets with safety, precision, and minimal risk of hypoglycemia. Now we start from treatment options. Hospitalized patients with hyperglycemia, whether from diabetes or stress, need individualized treatment because their condition can be unstable with irregular food intake, shifting fluid levels, and exposure to new medication or even contrast agent. Oral diabetes drugs are usually stopped. These drugs may be less effective in acute settings and can interact with other treatment. So insulin is preferred because it offers flexible, reliable blood sugar control and does not have drug-drug interaction, making it safer in complex hospital situations. Moreover, insulin is the preferred treatment for hospitalized patients with hyperglycemia due to its flexible dosing, rapid onset, and ability to adapt to changing physiology. It's easy to titrate, has no fixed dosage ceiling, minimal side effect aside from hypoglycemia, and no drug-drug interaction, making it safe and effective in complex clinical settings. Insulin remains the cornerstone of inpatient hyperglycemia management because of its safety, flexibility, and rapid action as mentioned before. Unlike oral anti-diabetic drugs which are often discontinued in hospital due to risks like hypoglycemia, renal impairment, and of course drug-drug interaction, insulin can be precisely titrated to match the patient's changing physiology. However, the insulin regimen itself is not one size fits all. It must be adapted based on the patient clinical presentation. This dynamic approach ensures that insulin remains effective and safe across a wide range of inpatient scenarios, while oral agents are paused due to their slower action, unpredictable absorption, and potential for harmful interaction. Here's the big picture. For hospitalized patients with hyperglycemia, insulin remains the preferred treatment as mentioned. Critically ill patients will be managed with IV insulin infusion. In a non-critically ill patient, regimen depends on nutrition. Basal bolus for those eating, basal plus and minus correction for those with poor intake. This section focuses on non-critically ill patient. IV insulin for critically ill cases will be discussed in the next part. First, we're gonna discuss the basal bolus regimen with reliable and consistent nutritional intake. Now, when managing hospitalized patients with diabetes outside of the ICU, the preferred approach is subcutaneous insulin. It is recommended for most medical and surgical patients because it allows flexible, responsive control of blood glucose. In contrast, oral anti-hyperglycemic drugs or OADs are not generally recommended in this setting. They may have delayed onset, unpredictable absorption, or pose risks like renal impairment or hypoglycemia, especially during acute illness or fasting. So in the non-ICU setting, insulin remains the cornerstone of safe and effective inpatient glycemic management. Now, when initiating insulin therapy in a hospitalized patient, we first discontinue all oral antidiabetic agents. general rule for basal bolus initial insulin dose calculation. For those who are insulin naive, we calculate the total daily dose typically between 0.3 to 0.5 units per kilogram. Lower doses are recommended for elderly patients or those with renal impairment. If the patient was previously on insulin, we reduce their outpatient dose by about 20 or even 25% to account for changes in activity and nutrition. We then apply a basal bolus regimen. Half of the total daily dose is given as basal insulin and the other half is divided into rapid acting doses before its major meals. Now, basal bolus insulin regimens has three key components, each with distinct role in controlling blood glucose. Basal insulin provides steady 24 hours coverage for the body's background insulin needs, even when fasting. Bolus insulin is given before meals to manage the rise in glucose from food. Correctional insulin is added as needed to fix unexpected hyperglycemia. It's not a replacement for scheduled doses. It is a safety net helping us respond to real-time glucose elevation without overcorrecting. Together, these three components offer a flexible physiologic approach that mimics natural insulin patterns and help us maintain safe, stable glucose level in hospitalized patients. Now, there are key studies compared basal bolus insulin to sliding scale insulin, or abbreviated as SSI, in hospitalized patients with type 2 diabetes, and that is RABIT-2 and RABIT-2 surgery. RABIT-2 stands for Randomized Study of Basal Bolus Insulin Therapy in the inpatient management of patient with type 2 diabetes. The original RABIT-2 focused on the general medical patient, while RABIT-2 surgery involved patients undergoing non-cardiac surgery procedure. Both studies showed that basal bolus therapy achieved better glycemic control than sliding scale regimen. However, in the surgical group, researchers observed a higher risk of hypoglycemia with basal bolus therapy. The likely reason for this is that post-operative patients often have inconsistent or reduced food intake, especially after abdominal surgery. Now, to address this, a complementary study, the Basal Plus trials, was launched testing simplified regimen for patients with unpredictable nutrition, aiming to reduce hypoglycemia while maintaining good glycemic control. Before I get into the Basal Plus trial, let me show you some of the result of basal bolus versus sliding scale regimen. Now, this is the result of RABIT-2 trial, the blood glucose trend on days of therapy. You can see no questions, basal bolus better, sliding scale regimen above 180, while basal bolus regimen below 180. In terms of hypoglycemia rates, pretty much the same. Low of less than 3% for blood sugar of less than 60, and none for less than 40 milligrams per deciliter for both. Now, about 15% of patients on sliding scale insulin experience persistent hyperglycemia with blood glucose level exceeding 240 milligrams per deciliter. Once these patients were shifted to basal bolus regimen for safety reason, and you can see the change was immediate. Glucose level dropped quickly and reliably, often within hours. This highlights the power of basal bolus therapy to restore control over sliding scale insulin regimen. And this is RABIT-2 surgery trial. Outcome frequency in percent. There is improvement in glycemic control and fewer post-operative complications with basal bolus therapy versus sliding scale. Improvement of the composite of hospital complications such as wound infection, pneumonia, respiratory failure, acute renal failure, and bacteremia versus sliding scale regimen. Now this is a basal plus trial in 2013 trial by Umperes et al. Compared basal plus and basal bolus insulin regimen in 300 non-ICU patients with type 2 DM. Basal plus used glargine 0.25 units per kilogram once daily plus correctional insulin for blood glucose more than 140 milligrams per deciliter. Basal bolus used a total daily dose of 0.5 units per kilogram, split 50% between glargine and pre-meal glulicin with dose reduction for older adult or renal impairment. And here's the result. You see result of basal plus versus basal bolus regimen. Both approaches achieve similar glycemic control, but basal plus required fewer injections and offered a simpler strategy, especially useful in patients with poor or inconsistent oral intake. For non-ICU patients with type 2 diabetes and blood glucose above 140 milligrams per deciliter, insulin therapy is recommended, and when calculating the starting dose, we need to consider nutritional status. If the patient is on NPO or has uncertain oral intake, we begin with a lower dose to minimize the risk of hypoglycemia. In contrast, patients with adequate and consistent nutrition can safely start at the standard dosing level. Now, in non-critically ill patients, full basal bolus insulin isn't always ideal, especially when nutrition is inconsistent and hypoglycemia risk is high. Alternatively, like the basal plus regimen, meaning basal insulin plus correctional doses, offers simpler control, as we've already discussed in detail. More recently, DPP-4 inhibitors have emerged as effective inpatient option, used alone or with basal insulin. They provide comparable glucose control with lower hypoglycemia risk and easier administration, making them suitable for stable non-ICU patients. Now here's are the two sitagliptin in hospital study. Sitagliptin in hospital type 2 DM, the two trials by Umperes, the pilot study, and Pascal, Sita Hospital compared sitagliptin plus basal insulin versus basal bolus in non-ICU patient. You can see both showed similar average blood glucose in the range of 154 to 171 milligrams per deciliter, and confirm that sitagliptin is safe, effective, and more convenient, offering a simpler alternative to multi-dose insulin therapy. We have another study on a DPP-4 inhibitors. Linagliptin inpatient trial overview. This randomized control trial evaluated the safety and efficacy of linagliptin for managing blood glucose in hospital general surgery patient in type 2 DM. The dosing protocols shown on the right outline treatment with either linagliptin 5 mg daily or a basal bolus insulin regimen. You can see both groups also receive correctional doses of rapid-acting insulin based on a sliding scale. The conclusion of this study is that for patients with mild to moderate hyperglycemia, blood glucose less than 200, undergoing a non-cardiac surgery, daily linagliptin proved to be a safe and effective alternative to multi-dose insulin therapy, offering comparable glucose control with fewer episodes of hypoglycemia. So the last one is saxagliptin. In 2017, BMJ Diabetes Research and Care Study evaluated saxagliptin versus basal bolus insulin in non-critically ill hospital patients with type 2 DM and mild hypoglycemia. Both groups received correctional insulin as needed. The study found that saxagliptin was non-inferior to basal bolus therapy, achieving moderately elevated average daily blood glucose level in both arms around 154 to 158 milligrams per deciliter. Saxagliptin provided similar glycemic control with a simpler regimen and a fewer hypoglycemic events. Then after reviewing all these available data, the recommended approach in general medicine ward is to tailor insulin therapy based on patient blood glucose level. For those with glucose below 200 milligrams per deciliter, treatment may begin with either once daily basal insulin plus correctional dose or a DPP-4 inhibitor such as sitagliptin or linagliptin also paired with correctional insulin. If blood glucose exceeds 200 milligrams per deciliter, more intensive strategies are considered. These include basal insulin alone or basal plus a DPP-4 inhibitor or a full basal bolus regimen when tighter control is necessary. This flexible framework allows the clinician to adjust therapy based on patient's clinical stability, nutritional intake, and risk of hypoglycemia, striking the balance between efficacy, safety, and simplicity. And that wraps up part 3 of our session on insulin strategies for inpatient hyperglycemia non-critically ill patients. Up next, we shift focus to the management of hyperglycemia in critically ill patients where treatment goal, risk, and strategies take on a different level of complexity. Thank you very much for listening.